This is a patient who has a crystal lens that is dislocated along with the whole capsular bag complex. I can see that there's a CTR in the capsular bag, so we're going to use this to our advantage to help reposition the whole lens bag complex. When I grab the anterior capsule with the forceps, I see that the whole lens bag complex can be shifted and positioned relatively easily. So my strategy is going to be to lasso the CTR to recenter the complex. Here I'm making a peritomy and some hemostasis is obtained with cautery. This is on the nasal side now, so the patient's nose is a little bit in my way, so I'm angling the patient to get that out of the way. This is a diamond blade, and I'm going to make a freehand radial groove about 1/2 thickness. I'm now going to enter the scleral groove about 3.5 millimeters posterior to the limbus, and again about 2 millimeters posterior to the limbus. A Goretex suture is placed in the lumen of a 30 gauge needle, and the needle has been bent to the appropriate angle for me to introduce it into the eye. I'm now going to pass the 30 gauge needle holding the Goretex suture under the posterior capsule, through the capsular bag, and I'm going to grab the suture with a micro forceps and pull it out through the paracentesis. So now we have a suture going under the capsular bag, through the capsular bag, and now we're going to bring the suture back in the eye. I'm going to pass a 25 gauge forceps through the sclerotomy made 2 millimeters posterior to the limbus and come out between the iris and the capsular bag, and I'm going to retrieve this end of the suture that I brought back into the eye. So now when I retrieve this, I'll have a lasso around the CTR. Here I'm going to hand the suture to my other forceps and pull it out of the eye. I can now adjust the tension on this to bring the whole lens bag complex into a central position. I'm going to do a single throw here to sort of just hold this in place. And I've decided to add another suture on the other side to provide better stability. So here I'm making a second radial groove exactly 180 degrees away. I'm going to enter with my diamond blade 2 millimeters posterior to the limbus, and again about 3.5 millimeters posterior to the limbus. We're going to introduce the Goretex suture using the 30 gauge needle under the capsular bag, through the capsular bag complex, between the optic of the lens and the CTR. And I'm going to pull the suture out of the lumen of the 30 gauge needle I've introduced it into the eye with, and then pull it out the paracentesis and reintroduce it. This creates a little bit of slack for me to work with. I'm going to retrieve the suture end with the 25 gauge forceps through the sclerotomy 2 millimeters posterior to the limbus, and we'll pull the suture end out through the sclerotomy, giving us a lasso around the CTR on the other side here, 180 degrees away. So now we have two lasso sutures holding the CTR 180 degrees apart. I'm going to adjust the tension and lock this Goretex suture with a single throw in the reverse direction, and then we'll make a final throw in the opposite direction. So there are 3 single throws. I'm going to cut this short and then rotate and bury this knot within the eye. And now the suture will lie at the base of our radial groove, where it won't cause any problems with the knot buried in the eye. We're going to do the same thing on the other side. Lock the suture after adjusting its tension, cut this short and rotate it into the eye. After this is done, we'll check the centration of the lens, which is very good, and close conjunctiva on each side with a 10-0 nylon suture. The lens is well centered here, but there's viscoelastic in the eye, and I assume that there could be some vitreous mixed in, so I'm going to inject some dilute essence to stain and look for vitreous, and remove the contents from the anterior chamber with the vitrector. And I can see that there is indeed some vitreous that has come up through the lens capsule, and I think it's best to remove this with the vitrector, as you see here, rather than to just blindly remove it with irrigation, aspiration, handpiece, and possibly tug on vitreous. After removing the vitreous and viscoelastic from the anterior chamber, I'll inject some Myocol to bring down the pupil. You can see when I do this how centered and stable the lens is. Now the case is completed, and this is what the patient looked like the next day in the office. Thank you for your attention.